Topic for today is Introduction to Blood Groups and Overview of Rhesus problem. Blood group systems. The two commonest systems for blood group classification are ABO system and Rhesus system. ABO system includes groups AB, AB and O antigens. Rhesus system we describe with capital C, small d has no, it is only the dominant, that is the positive we have, no, the small d is not there. E and E and G. There is no DAG. The letter represents absence of D antigen. Fisher-Race nomenclature describes the presence of three genetic loci, each with two major alleles. The RH gene complex is described by the three appropriate letters. So when we see this DD, CC and EE, so according to this, then there are 8 gene complexes which we can see on the screen. D positive, that is Rh positive phenotypes. Most individuals with a D positive red cell phenotype express a conventional RhD protein. However, more than 500 RhD alleles have been reported. These alleles can cause numerous variations in the expression of D antigen. An estimated 1% of individuals of European ancestry carry RhD alleles that encode altered D antigens, and the incidence in individuals of African ancestry is much higher, up to 30% in some populations. Altered D is organized into 4 groups: weak D, partial D, including category D, DEL, and non-functional RhD. Rhesus alloimmunization. The designation Rh positive usually indicates the presence of the D antigen, and Rh negative indicates the absence of D antigen on erythrocytes. As we can all see from these slides, most of the cases of Rh alloimmunization causing transfusion reactions or serious hemolytic disease in the fetus and newborn are the result of incompatibility with respect to the D antigen. Father's genotype is the key to fetal Rh type. This line is very, very important and all of us should register this. Father's genotype is the key to fetal Rh type. Rhesus positive father may be homozygous or heterozygous. So if the father is heterozygous, then half of the children will be Rh positive and the rest half will be Rh negative. Whereas if the father is homozygous positive, then all the children will be Rh positive. Impact of Rh on fetal and neonatal health. Following a worldwide study, it has been concluded that Rh hemolytic disease is a significant public health problem resulting in stillbirths. Following a worldwide study, it has been concluded that Rh hemolytic disease is a significant public health problem resulting in stillbirths and neonatal deaths, and is a major cause of severe hyperbilirubinemia and its sequelae, kernicterus and bilirubin-induced neurologic dysfunction. A French midwife first described the disorder in 1609. However, it was not until the 1950s when the underlying cause was clarified. Incidence of Rhesus negative population. There is a wide variation in prevalence rates of RhD negative individuals between regions. In India, almost 5% of the people are Rh negative, and in Asian population as a whole, 1 to 2%, 15% in North America, and 5 to 8% in African Americans. Globally, the Basque population of Spain has the highest incidence of Rh negativity to the tune of 30 to 35%. Out of these, 3.7 lakh cases of Rh hemolytic disorder worldwide are reported each year. India is responsible for about 56,672 of these cases. A hospital-based study reported an overall incidence of Rh alloimmunization to be nearly 1.3% in North Indian women during the antenatal period. The Rh alloimmunization rate was 10.7% and 0.12% in Rh negative and Rhd positive mothers respectively. So pathophysiology of Rhesus disease, as we see, Rh negative mother, when it is a first conception, the placenta acts as a barrier and there is no harm to the fetus. Then this we can say first pregnancy in a Rhesus negative mother with a Rhesus positive fetus is uneventful. So when any pregnancy in a non-isoimmunized rhesus negative mother with a rhesus positive fetus is uneventful. That means whenever the fetus is Rh positive, mother is Rh negative, but there is no isoimmunization, there is no problem. Any pregnancy in an isoimmunized rhesus negative mother with a rhesus negative fetus is uneventful. Obviously there are no antibodies, so there is no problem. If an isoimmunized rhesus negative mother has a rhesus positive fetus, then fetus is at risk of anemia. So from these slides we can see that the first pregnancy is almost always uneventful, and if the fetus is also Rh negative, then also there is no problem. Thirdly, if the mother is not isoimmunized, then also we are not in trouble. The only trouble is when the mother is isoimmunized and the fetus is Rh positive. Do all rhesus negative women respond as such? Rh alloimmunization occurs by one of the two mechanisms. That is, first is after incompatible blood transfusion. Secondly, after feto-maternal hemorrhage between mother and an incompatible fetus. Studies have suggested that up to 30% of persons are non-responders with Rh negative blood who never develop Rh incompatibility even when challenged with large volumes of Rh positive blood. Hence, it is important to screen rhesus negative women for those at risk of hemolytic disease of fetus and neonate. Other aspects of history to be explored include whether there is a history of prior blood transfusion and its results, whether any reaction was there or not, all previous pregnancies, their outcomes and interventions. History of hydrops is very, very important. If there is a history of hydrops, then there are 90% chances of recurrence. Previous administration of Rh immunoglobulin, mechanism of injury in cases of maternal trauma during pregnancy, presence of vaginal bleeding or prior invasive procedures. Rhesus negative women, once she reports to the antenatal clinic, her husband's blood group and Rh status should also be done. Check ICT for pre-existing antibodies. If ICT is negative, it indicates no antibodies, which is reassuring. Prevention of rhesus isoimmunization, FOXI guidelines 2022. So here we see that during pregnancy, rhesus D, that is D negative women who carry an RHD positive fetus are at risk of being sensitized to produce immune anti-D antibodies following a feto-maternal hemorrhage, including leading to hemolytic disease of the fetus and newborn. So HDFN induces fetal anemia with increased risks of fetal death, severe neonatal hyperbilirubinemia and kernicterus. So the objective of the guideline is to provide healthcare professionals with practical guidance on the use of anti-D immunoglobulin as immune prophylaxis to prevent sensitization to the D antigen during pregnancy or at delivery to prevent hemolytic disease in the fetus and newborn. So the blood group in and Rh we are already doing, all of us are doing, and it is very important that once we have detected that the mother is Rh negative, that she should be informed. She should know that what are the implications of being Rh negative. And Rh negative women should ideally have an indirect Coombs test for screening of Rh antibodies at first antenatal visit. This is preferably done irrespective of the husband's Rh status to ensure that prior sensitization events are not missed. If ICT is negative at the first visit, then ICT should be repeated at 28 weeks. However, if a woman has had anti-D immunoglobulin following a sensitizing event or routine antenatal prophylaxis, subsequent ICT is preferably not done. If ICT is done after anti-D prophylaxis, the results should be interpreted with specialist consultation. At the time of delivery, for all Rh negative mothers, documentation of the blood group and the Rh status of the neonate must be done. So sensitizing events requiring anti-D prophylaxis, if they occur before 20 weeks, that is, the sensitizing events include significant bleeding during threatened abortion, spontaneous miscarriage, medical termination of pregnancy, surgical termination of pregnancy, ectopic pregnancy, H-mole, chorion villus sampling, embryo reduction, amniocentesis and other invasive fetal procedures. So in all these cases, the dose recommendation is 150 micrograms of the NTD, but as we all know, 150 microgram is not available so easily. So it is preferred to give 300 micrograms in these patients also. So after 20 weeks, if the sensitizing events include abruptio placentae, blunt trauma, intrauterine fetal demise, external cephalic version, placenta previa with bleeding, and invasive fetal procedures. So the recommended dose, as I have already said, 150 micrograms in less than 20 weeks, and after 20 weeks it is 300 micrograms intramuscularly in the deltoid region. So in the routine antenatal NTD prophylaxis, Rh negative women may have silent bleeds in the third trimester, resulting in isoimmunization. To protect against this, antenatal NTD prophylaxis was introduced. A single dose regime of 300 micrograms intramuscularly in the deltoid region is effective, economical, and offers better compliance. A single dose regime is equally effective as a two-dose regime. Routine antenatal NTD prophylaxis should be given only if the ICT is negative at 28 weeks. So postpartum NTD immunoglobulin administration. For all Rh negative mothers, cord blood testing of the baby should be done. If the baby is Rh positive, 300 micrograms IM should be administered through deltoid within 72 hours. If NTD administration is missed during the first 72 hours window, in the first 72 hours window, it is advisable to give it as soon as possible. Partial to complete benefit has been noted for up to 10 days and some benefit for up to 28 days of giving NTD. If delivery occurs within 3 weeks of the routine antenatal NTD prophylaxis, then NTD administration in the routine postnatal prophylaxis can be withheld in the absence of excessive fetal-maternal hemorrhage. But if we do not have facility for knowing the quantification of fetal-maternal hemorrhage, then it is better to give the postpartum NTD rather than missing it. So the special circumstances are in women undergoing tubal ligation, NTD prophylaxis must be given to prevent isoimmunization. This is important if the woman chooses to have another pregnancy, ligation fails, or she requires future cross-matching of blood products. In cases of recurrent sensitizing events, a repeat dose is required if the event is 3 weeks apart. If Rhd positive blood or blood components are transfused, prevention of sensitization protocol should be done in consultation with the hematologist. Some women have conflicting Rh status reports or have weak NTD. Such women are best discussed with a hematologist or considered Rh negative and treated with NTD immunoglobulins. In women in whom there is a contraindication to an intramuscular injection, such as the ones with thrombocytopenia or blood dyscrasias, appropriate intravenous preparation of the NTD immunoglobulin can be used with hematologist consultation. So it is better that we prophylactic use of Rh immunoglobulin. This is the repetition. It is screening by ICT at 28 weeks, routine NTD at 28 weeks, postnatal NTD within 72 hours, sensitizing events, assess the dose, if possible, quantify fetal-maternal hemorrhage. Failure to prevent Rhd alloimmunization. Failure of alloimmunization occurs when there is failure of administering antenatal prophylaxis in the third trimester of pregnancy, or if insufficient dosage or timely administration, that is within 72 hours of NTD immunoglobulin has not been given, or when there is a sensitizing event or after birth, if the proper dose has not been given, an unrecognized fetal maternal hemorrhage at some point in the pregnancy. An additional reason for Rhd alloimmunization is the small rate, 0.1 to 0.2% of spontaneous immunization despite adherence to the recommended prophylaxis protocol. In other words, prophylaxis is not 100% effective. So these are the tests for fetal-maternal hemorrhage. Klehr-Betke test is age-old. We have been listening to it and studying it. It is based on acid elution technique. Fetal and maternal RBCs have different response to citric acid phosphate buffer solution. Maternal cells containing adult hemoglobin get eluded, leaving behind only cell membrane and hence appear as swollen round large ghost cells against normal fetal cells whose hemoglobin remain unaltered, hence they look as red refractile round cells. If in 50 low power fields of maternal peripheral blood, 80 fetal RBCs are found, it is estimated that 4 ml of fetal-maternal hemorrhage has occurred. For 1 ml of fetal blood, 10 micrograms of rhNTD is needed. Therefore, 300 micrograms NTD will be sufficient for 30 ml of fetal blood which has entered the maternal circulation. Flow cytometry is another method by which we can calculate the fetal-maternal hemorrhage. Flow cytometry is a specialized technique that is an alternative method available in some hospitals for quantification of fetal-maternal hemorrhage. Its use is limited by equipment and staffing cost. Flow cytometry uses monoclonal antibodies to hemoglobin F or the Rhd antigen with quantification of fluorescence and is highly sensitive and accurate in identifying fetal red blood cells in maternal blood. Both KB test and flow cytometry. Welcome, Dr. Aparna. Please come. Both KB test and flow cytometry can be used to quantify the fetal-maternal hemorrhage. This information can be used to plan the dose of NTD. That is, we know 10 microgram neutralizes 1 ml of fetal blood. So 300 microgram of NTD or 1500 international units can neutralize 30 ml of fetal blood or 15 ml of RBCs, or 100 micrograms of NTD is equivalent to 500 international units of NTD, which can neutralize 10 ml of fetal blood or 5 ml of RBCs. What are the best screening methods for detecting alloimmunization in women? All pregnant women should be tested at the time of the first prenatal visit for ABO blood group and Rhd type and screened for the presence of erythrocyte antibodies. These lab assessments should be repeated in each subsequent pregnancy. Repeated antibody screening before administration of NTD immune globulin at 28 weeks of gestation. So ICT positive, ICT is a qualitative test. Once positive, the titers of antibody can be assessed quantitatively. Titer values are reported as of the greatest tube dilution with a positive agglutination reaction, 1 in 16, 1 in 32, 1 in 64. The critical titer is associated with a significant risk for severe erythroblastosis, fetalis and hydrops, and is in most centers this is around 1:16 or 1:32. Rhesus variations, as I've already said, it could be weak D or partial D. The weak D phenotype is due to a reduced number of D antigens on a red blood cell, a quantitative difference in the D antigen. In contrast, the partial D phenotype is due to an alteration in the D antigen. Therefore, in partial D, the number of D antigens is not reduced, but the protein structure is altered. These individuals, if alloimmunized to D, can produce an antibody due to a qualitative difference in the D antigen. More than 30 different partial D phenotypes have been identified. The practical implication of this is that people with this subphenotype will have a product labeled as D positive when donating blood, but when receiving blood, they are sometimes typed as D negative. Rh null individuals have no Rh antigen on their red blood cells. This rare condition has been called as golden blood. As a consequence of Rh antigen absence, Rh null red blood cells also lack LW and FY5 and show weak expression of SS and U antigens. Red blood cells lacking Rh antigens proteins have structural abnormalities such as stomatocytosis and cell membrane defects that can result in hemolytic anemia. Only 43 individuals have been reported to have it worldwide. Only 9 active donors have been reported. So these are the tests which, in addition to identifying the ABO and Rh, which we can do to know the minor variations in the D antigens. So other ancillary tests should follow identification of maternal antibodies to diagnose hemolytic disease in the fetus. That is determination of paternal genotype, that is homozygous, 100% fetus is Rh positive. Heterozygous, only 50% of the fetals will be positive and rest negative. Determination of fetal genotype, nowadays with the help of cell-free DNA, amniocentesis or with CVS, we can find out the blood group of the fetus. Spectral analysis of amniotic fluid is not done these days. Fetal middle cerebral artery Doppler, PSV, is the current practice. People do monitoring of these fetuses with this mode of investigation which is available to us. Current practices, once a woman is known to be isoimmunized, it is better to follow up the fetus rather than repeated titers. Fetal risk is of anemia. Fetal anemia can be detected by the middle cerebral artery peak systolic velocities on Doppler. So this will be covered in detail by Dr. Aparna. Prevention is better than cure. So in all these cases, we have already seen that sensitizing events, we must give NTD to the patient. So this is fetal RH status test. It is available. We can use this in cases of patients who do not have any live issues and are RH negative and who have already been isoimmunized. There is a 0.1% chance that the result, sometimes these results will show RH negative fetus when it is actually RHD positive. This equates to approximately 1 in 1000. However, of that 1 in 1000, only 1% will develop immune NTD. NTD will be offered at delivery if the baby is found to be RHD positive. There is a 2% chance that the test will show RHD positive and actually the fetus is RH negative. This means the mom will have NTD unnecessarily, but it is okay. Giving NTD is less harmful than not giving it. The incidence of post-pregnancy RHL immunization has decreased to 1 to 2% after postpartum NTD immunoprophylaxis. The incidence of RH immunization during pregnancy further reduced from 1.8 to 0.14 with RH immunoprophylaxis, 300 micrograms of NTD immunoglobulin at 28 weeks. So medico-legal implications are the informed verbal consent must be taken before administering the NTD antenatally. It must be documented in her discharge card and case sheet, preferably with details of the product. In case of refusal, written consent regarding refusal must be documented and signed by the patient. There is no evidence to suggest that NTD administered to women during pregnancy is harmful to the mother and fetus. So dosage we have already discussed. So to summarize, blood group RH must be checked at an antenatal visit. If Rhesus negative ICT, if the patient is Rhesus negative, ICT must be done as soon as possible. Any sensitizing events in a Rhesus negative pregnancy must alert one towards feto-maternal hemorrhage. Adequate NTD prophylaxis can help prevent isoimmunization. If still isoimmunized, follow up with fetal middle cerebral artery Dopplers at centers where IUT is possible. Thank you.